All right, let's get straight into it. Welcome to today's explainer on neurosurgical trauma. We're bypassing the basic test prep filler today and going straight into the granular mechanical cascades and the highly complex decision boundaries you are going to face in the trauma bay. We're going to look at the exact physiological details and specifically the multi-state management exceptions where very subtle variables can completely shift your clinical approach.
Here's our roadmap for the explainer. We'll be hitting intracranial hemorrhages, herniation mechanics, hypertension dynamics, the decompression ladder, and finally, we'll wrap up with clinical variants. Starting right off with part 1, intracranial hemorrhages and their diagnostic foundations.
Okay, so look at the stark biomechanical contrast between these two pathologies. We're talking about high-pressure arterial lacerations on one hand versus low-pressure venous ruptures on the other. It's not just basic anatomy, right? It's really about the velocity of deterioration. Let's break these down. Take an epidural hematoma. Usually, we're dealing with blunt trauma to the temporal bone, a lateral skull fracture that actually tears the middle meningeal artery. Now, because the dura is so tightly anchored to the skull's suture lines, the blood has nowhere to go but to expand inward, giving us that classic biconvex or lens-shaped hyperdensity on a CT scan. But here is the absolutely crucial takeaway. You have to anticipate the rapid clinical crash that follows the classic lucid interval. The patient gets knocked out, wakes up, and seems completely fine. Do not let that fool you. As that arterial blood pumps and expands against the dura, they are going to precipitously crash. They need emergent neurosurgical evacuation, period. Conversely, subdural hematomas are venous. They typically happen when dural bridging veins rupture. Since this bleeding occurs between the dura and the arachnoid membranes, it easily crosses suture lines, which creates that classic crescent shape. Now, you really need a high index of suspicion here, especially in patients with cerebral atrophy. Think the elderly or chronic alcohol users. That atrophy physically stretches those bridging veins, making them incredibly vulnerable to even minor bumps to the head. And because it's a slower venous bleed, presentations can be all over the map, from acute to a really subtle subacute or chronic decline over days or sometimes even weeks.
Moving right along to part 2, mechanical cascades and herniation cinematics.
So when an intracranial mass starts expanding, remember that the adult skull is a rigid, closed box. The brain literally has nowhere to go but down. We see a few different physical trajectories here. There's subfalcine herniation, shifting across the midline, central herniation pushing straight down, and tonsillar herniation, which drives the cerebellar tonsils right through the foramen magnum, which is rapidly fatal because it compresses your respiratory centers. But right now, I really want to focus your attention entirely on pathway number 1.
This is uncal or transtentorial herniation. The uncal gyrus of the medial temporal lobe is literally being displaced downward, right over the tentorium cerebelli. You have to immediately recognize this when a patient presents with an ipsilateral, down and out, or completely blown unreactive pupil. Why does that happen? Because the herniating brain tissue is physically crushing the ipsilateral third cranial nerve. It can also compress the posterior cerebral artery, leading to a contralateral homonymous hemianopsia. But that blown pupil, that is your absolute blaring red flag signaling imminent catastrophic brainstem compression.
All right, let's hit part 3, intracranial hypertension dynamics. So when intracranial pressure, or ICP, spikes, your body tries desperately to maintain cerebral perfusion pressure. We want that CPP around 60 to 70 millimeters of mercury. The terminal result of this struggle is the Cushing's triad: systemic hypertension, bradycardia, and irregular respirations. But listen closely. Never, ever wait for Cushing's triad to act. This is not some early warning system. It is a terminal, pre-arrest reflex. If you're seeing the triad, the brainstem is actively being compromised, and it demands instantaneous, emergent intervention. Before we hit those terminal reflexes, we absolutely have to catch the earlier, subtler signs of rising pressure. A sudden onset of drowsiness or confusion in a trauma patient? Massive red flag. We're also looking for severe headaches, vomiting, or papilledema on a fundoscopic exam. Interestingly, you might also see a cranial nerve 6 palsy, which causes double vision. This is famously known as a false localizing sign. Because the 6th cranial nerve has such a long intracranial course, it's highly susceptible to being stretched purely by generalized elevated ICP rather than by a specific focal lesion. Next up is part 4, the stepwise decompression ladder. When ICP is climbing and becomes refractory, we have to follow a very strict escalation pathway to buy time for definitive treatment. This sequence is non-negotiable. First, we optimize sedation and raise the head of the bed 30 degrees for simple gravitational drainage. Then, we step up to osmotic therapy. Next is short-term hyperventilation. And finally, aggressive mechanical offloading with an extraventricular drain or a decompressive craniotomy.
Let's zoom in on step 2. The crucial mechanism here is that osmotic therapy, using IV mannitol or 3% hypertonic saline, works by chemically extracting intracellular water specifically from the preserved healthy brain tissue. It creates this powerful osmotic gradient that literally pulls fluid out of the brain parenchyma and into the vascular space so it can be excreted. Now, this doesn't fix the original bleed, but it temporarily lowers the overall intracranial volume, buying you those absolutely crucial minutes needed to get the patient to the OR.
Now, there is a very strict, very dangerous exception surrounding therapeutic hyperventilation. By hyperventilating the patient, you reduce their arterial PCO2 down to about 30 or 35 millimeters of mercury. The brain is exquisitely sensitive to CO2 levels, so this hypocarbia drives acute cerebral vasoconstriction, which rapidly reduces intracranial blood volume and drops the ICP. But here's the catch. You must restrict this to a very brief window, strictly less than 30 minutes, and only during acute, impending herniation. If you maintain prolonged hypocapnia, that same vasoconstriction will trigger severe, widespread ischemic strokes. You're effectively starving the brain of blood flow in an attempt to save it from pressure.
Let's bring this all together in Part 5, Clinical Reconciliation and Trot Variants. You know, this really captures why just memorizing generic pathways completely falls apart in the chaos of the trauma bay. When physiological exceptions occur, rigid thinking leads to catastrophic surgical errors. Let's look at exactly how this happens in practice. Imagine this high-stakes scenario right in front of you. A patient rolls in with a severe blunt strike to the left temporal region. They quickly develop a blown, dilated left pupil. Okay, that makes sense. An expanding left-sided mass is compressing the left third cranial nerve. But then you notice their motor weakness, their hemiparesis, is also on the left side. Wait a minute. This completely defies standard neuroanatomy, right? Motor tracks cross over in the medulla, so a left brain injury should cause right-sided weakness. If you assume the weakness points to a right-sided bleed and take them to surgery to open the right side of the skull, you are falling into a fatal trap. So here is exactly how you resolve that variance. That expanding epidural hematoma on the left is so massive that it's pushing the entire midbrain completely across the midline. It's displacing it so violently that the right side of the midbrain, specifically the contralateral cerebropeduncle, is getting crushed against the hard fibrous edge of the tentorium on the right side. That anatomical pinch point is called Kernahan's notch. Because that right peduncle carries the motor fibers for the left side of the body, crushing it causes a paradoxical, false localizing sign of ipsilateral left-sided weakness. The blown pupil is the one telling the truth here. The primary massive bleed is on the left. You absolutely must cut on the side of the blown pupil immediately. Recognizing that Kernahan's notch phenomenon means you skip all further conservative steps on the decompression ladder. No decoys. You proceed directly to an emergent, ipsilateral decompressive craniectomy on the left side. You remove the bone flap and open the dura to evacuate the hematoma. You have to let that lethal cerebral edema expand outward rather than downward into the brainstem.
Which leaves us with a critical question to ponder before our next shift. We just saw how easily paradoxical signs can mislead us if we don't understand the underlying mechanical cinematics. But what other absolute clinical thresholds might we be blindly missing? Think about brain death criteria. You have to rigorously verify the complete absence of brainstem refluxes, ensuring there are no confounding depressants and the core temperature is well above 36 degrees Celsius. And you need to master the acute apnea challenge, right? Pre-oxygenating with 100% O2, disconnecting the ventilator, and waiting 8 to 10 minutes to see if PCO2 climbs past 60. But what's the emergency exception? What if your comatose trauma patient drops their blood pressure to 70 systolic 2 minutes into the apnea test? You have to know to abort the test immediately, reconnect the vent, and pivot straight to a radionuclear cerebral blood flow scan. You can't just repeat clinical trials on an unstable patient. We have to constantly push our understanding of these granular boundaries. Thanks for tuning into this explainer, and I'll catch you next time.